Next. Well, these are things that we've talked about over and over again. Here is everything officially for you in words. Aldosterone, reabsorption of sodium, excretion of potassium. Sodium diffuses into the cell. The primary site here with potassium is to get rid of it for aldosterone. Sodium-potassium pump, you know its activity. With aldosterone, it'll reabsorb the sodium and gets rid of the potassium. Ultimately, if you have too much aldosterone, it may result in hydrogen getting rid of and may result in getting rid of your potassium and hypokalemia. The bicarb is reabsorbed into the ECF, causing metabolic alkalosis. So remember, whenever there is issues with hydrogen, you're getting rid of it. As soon as you think about hydrogen and bicarb, you're thinking about that formula. And for the most part, and even though it's not pictured, I assume that you know at this juncture with hydrogen and bicarb, they're going to be all part of that carbonic anhydrase formula, aren't they? And what kind of direction are they always moving in with bicarb and hydrogen in opposite direction? So wherever hydrogen is going, let it be into the lumen or into the blood, bicarb will be moving in the opposite direction. Here, hydrogen will be moving into the urine with the help of aldosterone, and then your bicarb will be coming out into the blood, all contributing to your metabolic alkalosis. Now, a couple of important potassium-sparing drugs that you want to keep in mind, especially, for example, let me give you a clinical situation. You have a patient who has hypokalemia secondary to loop diuretics, correct? And so therefore you might want to think about giving that patient a potassium-sparing drug. With the Miloride and Triamterene, it's a little bit different, isn't it? Because these are not drugs that work on the aldosterone receptor. These are drugs that work on the luminal, highlight that in your head, membrane sodium channel, inhibits sodium reabsorption, and thus inhibits potassium excretion. Isn't that the point of these drugs? Is to spare the excretion of potassium, isn't it? The effect of increased distal delivery of sodium, pay attention, loop or thiazide, the increased delivery of sodium because you're blocking the sodium channels of different types. Loop, where are you? Thick ascending limb. Thiazide, where are you? DCT. Well, the diuretics acting proximal to this channel, augmented sodium reabsorption and potassium excretion, may produce hypokalemia if potassium supplement are not taken. So oftentimes, when there's going to be increased delivery of sodium, please understand that sodium is going to try to be reabsorbed and potassium potentially could be lost. Hypokalemia may produce metabolic alkalosis. So you could think of this as being a natural form of aldosterone, and this is a problem when you give such diuretics that end up increasing delivery of sodium. So effective increased distal delivery of sodium from loop and thiazide diuretics acting proximal to this channel. What channel? Proximal to the collecting duct. And if you increase the delivery of sodium to it, and whatever the cause may be, keep this in mind, that it behaves like a natural aldosterone. It'll do everything in its power to reabsorb sodium, gets rid of potassium, and gets rid of hydrogen. Do not forget that, please. That is an important point clinically.